Good morning, everyone. Thank you, Jesse, for setting the scene for us here. My case study is on a tube-feeding patient who I believe was already on their way to malnutrition. What the patient had is called toxic epidermal necrolysis. And I'm just going to give you a brief overview of what this is. It is actually a life-threatening drug reaction. So this person was perfectly healthy to begin with and had no idea that they would have this reaction to this particular medication that he took. But anyway, this destruction of the epidermis or the skin of the mucosal layer is attacked. So the skin of the body is attacked, and it almost looks like it's an actual burn. And it typically involves the eyes, and it usually involves greater than 30% of the body surface area. It is associated with high mortality rates between 25 to 30%. And the mortality is usually a result of the secondary metabolic failures and septicemia that the patient obtains or gets as a result of having this acute acute disease. And the mortality is also due to a loss of epidermal integrity. And we all know that our skin is an organ, but it's our first protection that we get. And so when that is damaged, boy, we are very susceptible to getting very sick. So this is what toxic epidermal necrolysis looks like. This is not the patient. And it looks, again, like an actual burn. And I saw another picture in which a girl had this particular reaction happen to her from taking a medication, and it looked like she was a burn patient from head to toe. But what's good to know is that patients do recover from this. As awful as it looks, full recovery can happen. But it is important to get immediate medical care right away. The usual treatment is that these types of patients are treated in a burn unit. It is very important to go to a hospital where there is a burn unit because the staff there are especially trained to take care of these types of patients, and they have the specialized equipment that they need in order to take care of these patients, and especially in order to facilitate appropriate wound care. But it is very important to withdraw the drug from the body that the patient took in, whichever one it is. It is vital in the early stages. Debridement of the necrotic tissue is implemented most of the time. It's highly recommended. It is so important to take off surgically the infected tissue or other infected types of skin that is on that person so that the wound can continue to heal. Otherwise, that damaged tissue can impede the healing, or it can cause more infection to take place. And wounds have to be covered with gauze and antiseptic ointment, just like regular burns. And it's important to monitor the fluids and the electrolyte status of the patient because of increased water losses from the wounds. And 3 to 4 liters of fluids per day are lost when at least 50% of the total body surface area is affected. Nitrogen and energy requirements are, I know you can assume it's got to be high, and they are. It's due to the wound exudates that are lost from the wounds. And the wound exudates are the fluid that comes out of the wounds that are primarily containing with protein and other substances in there, but they are definitely in a hypermetabolic state due to their wounds all over the body, and many of them also end up having sepsis. And one thing about this particular injury is that the oropharyngeal mucosa is affected. So it makes eating, it makes swallowing very difficult, and it makes drinking difficult. It makes the patients actually choke to a certain degree. And so they can't really eat on their own. and we need to help them out. And actually placing a tube down them can be a little bit difficult because of the mucosa that has been damaged. And these patients are also sedated and intubated as well. And of course, they have a naso or an orogastric tube that is placed down them. So this particular patient is a 63-year-old male who is admitted to this county hospital with a 60% total body surface area toxic epidermal necrolysis. This patient was previously at another hospital, at a veterans hospital, but because the patient was not healing, was not getting any better, that particular hospital said, you know, we need specialized care. We need to send him somewhere else where they really specialize in burns. So this patient is 183 centimeters and actually came in at a weight of 80.7 kilograms and was discharged at 81.3 kilograms. So he didn't lose weight, but fluid might have been an issue here. His ideal body weight is 81 kilograms, and his ideal body weight, he was at 100%. We don't know what his usual body weight was because the dietitian wasn't able to talk to the patient because he came in, he was sedated, but his BMI was good. It was 24. He is single, he's white American, and he's a truck driver. And we believe, or the dietitian believes, that the patient didn't really have any family responsibilities. It looked like there were no immediate family that was visiting him at the hospital. However, what they do know is that the patient lives with his nephew. And all this other information about him was not able to be obtained because no one could talk to him. In the charts, though, from the previous admission, from the previous hospital that the patient was transferred from, they found out that he doesn't have any past medical history and he had no previous admissions to any other hospital. So history of the current admission, he was transferred to the Perm unit and he had progressively worsening 60% total body surface area of the toxic epidermis necrolysis with a progressive TBSA lesions. So he was getting worse. He was not improving. During this admission, they found a maculopapular rash. He had a desquamation of his scrotum and mucosa of his eyelids, his lips, his mouth, and possibly his lower airway. So desquamation is meaning when the skin is sloughing off, and that's due to this acute injury. And also he had multiple petechiae and bullae, a lot of blisters throughout his body, on his head, his palms, the soles of his feet, as well as his back. His eyes were swollen shut from crusted mucosal desquamation and discharge. Oh, I accidentally put eyes there twice too. I'm following in Jesse's footsteps, putting things in twice. And his nasal cavity was putting out copious amounts of desquamation and discharge. The complications that he had was that he had a compromised airway. He could not breathe on his own, and so that's why they had to intubate him. And it was due to the mucosal involvement of the disease. And on top of that, he had an ileus. He had an obstruction. Things were not going through his GI tract. It was secondary to dilated loops of bowel. And then, of course, he was intubated. So these were the tests that were taken from him. Many tests, several tests were taken. On July 2, they did an abdominal x-ray, and it showed probable ileus secondary to the dilated loops of bowel. 3 days later, they took another x-ray of his abdomen to see how things were progressing, but it showed a distension of his right transverse colon. So you see, he really needed nutrition support of some kind. And on the 26th, his chest x-ray showed they tried to put a tube down him, and this particular tube is called the Dobhoff, and it retracted into his esophagus. So we're not making any headway at this point with his tube feedings. The next day, they did another abdominal x-ray, and it showed, okay, it has gone down to the duodenum, and we still have a distended large bowel. On the 29th, they did a tracheostomy, and they did a swallow evaluation by the speech therapist, who said that the patient really needs to be in the status of NPO, not feeding him anything by mouth, and that we really need to continue feeding him with tube feedings. I don't have many labs here because not many of the labs are provided to me, but the only thing that we have at this point, here are the few labs we have. Of course, we would see that the albumin is 2.1, and as Jesse spoke, it's a negative reactive phase protein, so it's partly low for that. But I don't know how long he was in the other hospital to begin with, and how well he was also being fed there too, if he was on tube feedings or not. His BUN from July 22 to July 28 were higher than normal. They were 25 to 30. And usually BUN normal, at least at Loma, it's 7 to 20. In different hospitals, it might slightly differ depending on the instrumentation being used. But the creatinine, sodium, and potassium happened to be within normal limits during this time that he was there. But as you can see, his hemoglobin was low. It hovered between 7.7 to 9.5. Of course, he was on many medications, a pain medication, insulin, another pain medication, stool softeners, another stool softener, a medication to help him sleep, antibiotics, a bronchodilator, an anticoagulant, an anti-GERD medication, and they gave him fish oil, anti-inflammatory. Of course, this patient was definitely in a state of inflammation. So this is what the dietitian and the physician tried to do. On July 22, they started the patient on tube feeding with a formula called Impact. Impact is a specialized tube feeding formula with special elements added to it in order to help certain patients. And in this case, it's to help those who are very critically ill. It's an immune modulating formula, and arginine is enhanced or added to it typically, and it's used for burn patients. And it was recommended by the RD, by the registered dietitian, that the amount or the rate that the tube feeding should be run at should be at 85 milliliters or cc's per hour. That's the goal in order to provide the patient with his total needs, which would be about 2,000 calories and a high amount of protein, 114 grams of protein. They added a glutamine supplement called Glutazol. Glutamine has been shown to help with wound healing. So they were thinking that would help his situation. The total calories and protein of Impact and Glutazol together provides that's 2,220 calories and 145 grams of protein per day. That's the goal. However, there are some days in which the tube feedings has to be stopped because tests have to be taken, etc. And so it's kind of like, oh boy, they're not going to be getting those calories and protein that the patient needs when the tube feeding has to be stopped for procedures and for tests. On the next day, the tube feeding was turned off due to his ileus. So nothing was going through. So it's like, oh great, now we can't feed him. But his residuals were just about 100 milliliters or cc's, which is, not too bad. But his abdomen was soft, but it was distended. There was no bowel movement. 3 days later, they were able to get the tube feeding up to 85 milliliters per hour. And they checked the residuals every 12 hours, and the residuals that they got was about 220 milliliters. So that was okay. He was tolerating it pretty good, not too bad. But then the patient was actually not tolerating the tube feeding as well. When they took the residuals, it went beyond, I believe, their requirement. They just liked residuals at that particular hospital to be 250 cc's or milliliters, but it was at 300. So they had to slow down the tube feeding to 40 milliliters per hour. So although the tube feeding is being run, it's not actually at the rate that the dietitian had actually calculated the patient needs. A day later, they were actually able to increase it a little bit more to 50 milliliters per hour. On the 28th, the tube feeding was stopped because the patient was having emesis. He was vomiting. But it was restarted at night, at midnight, at 50 milliliters per hour. He was actually getting better medically, although nutritionally he wasn't successful. But the tube feeding rate on the 29th was put up to 60 milliliters per hour by the afternoon. And then the patient had to be transferred back to the hospital that he came from. Now, the reason why I actually chose this one is because when patients are not able to eat on their own to begin with, they're already at great risk of going into malnutrition. And of course, we can't make them eat and tell them, hey, wake up and eat, or force them to eat, so they need help. And because of his state of inflammation, his needs are greater than what he is even capable of taking in if he was able to eat on his own. And so because of his catabolic state, that also puts him at another risk of having malnutrition. And then with all of the incidences of having an ileus, having to stop and check residuals, having to stop the tube feeding because they need to do a debridement to go to a procedure, that stops the tube feeding from happening. So we can't always have that goal of 85 cc's to provide the 2,200 calories, 2,220 calories a day. It doesn't happen, and so there are times that we actually just have to work around the situation, but malnutrition takes place because we're not able also to meet his needs because of these other things that have to take place medically. Now, they transferred him back to their hospital. They didn't get his tube feeding up to where they wanted to by the time he left, but there will be times that you might work at a hospital in which, okay, at least do what you can while they're in the hospital that you're at. And whatever it can take to prevent him or her from getting worse. And then hopefully when they are progressing at the other hospital, that the dietitian will pick up and continue to carry on the work. But that's the thing. We do the best that we can, and we use our expertise to be able to help control the situation as best as we can. But there are a lot of times that the other situations go against us, but we still do our best. Malnutrition is something we try to avoid for our patients, but sometimes it still happens. And I pray and hope that this patient continued to do well. That's a good sign that they transferred him back to their hospital where they don't have that specialized care. So he must have been doing better. But I know that also when the nutritional status is not up to par, it can also make the healing process, the wound healing process, it can delay that too. So we have to do our best to help our patients get their nutritional status up as best as we can with them. Thank you.